Hi, I'm Doug, and this is the RT-102 trigger. We'll be doing the complete procedure, start to finish, from the computer, to the tube, to the patient, and the actual image-taking procedures, to scanning the images and evaluating them. We will be doing chest, PA and lateral, and we'll also be doing knee, AP, medial, oblique, lateral, sunrise, and tunnel. So first, before I get the patient, before anything else, as soon as I get the rec, I set up on the computer. Patient's name, patient's gender, patient's date of birth, and start. Okay. First we'll be doing a PA chest, then a lateral chest, and we'll be doing an AP knee. We'll be doing a medial oblique, internal rotation knee. We'll be doing a lateral knee, doing a sunrise knee, and a tunnel knee. Sunrise is also known as the step cast, and with the tunnel we'll be doing the Camp Coventry method. So now that I have all these 7 lined up in the computer, hit start study. If I were in the actual clinical, I would suspend that, go take the images, then bring it back up. Okay, so we need to get ready to time to detent the tube and set the room up for the patient. The SID for a chest is 72. 72 inches. Thank God for iVideo, right?
Yeah.
We'll put in a 14 by 17 IP crosswise with the green marker on the patient's right-hand side. I like to put my marker in the upper left, out of the patient's anatomy, making sure the marker is facing away from me so it shows up the right way, the correct way, when the computer brings it up. Okay, now the time to set my technique. A good technique I like to use for an average size male adult, roughly 110 at 8. 110 kVp at 8 max. Set the technique. So now the tube is properly detented, the IR is in the bucky, and my console is set up. Time to bring the patient in the room. We're going to pretend this guy can stand. Okay, sir, what's your first and last name, date of birth? That matches my rec. I'm going to double check his wristband because he has one. Good. The patient is who I think it is. If female, I'm going to ask if she's pregnant. We're going to have the patient change into a gown and obtain the patient's history, ask them the onset and how long it's been bothering them, the problem, and anything else I should know about that. So here's where I have the patient change into a gown. The patient is changed into a gown. I like to leave my shield right here when I do chest x-rays to make sure I don't forget. I'm going to shield the patient. Now we're going to have the patient stand up against the board, chest lightly up against the board. I'm going to have the patient roll his shoulders forward, take the back of the patient's hands, put them on the patient's hips, move forward, and the patient's mid-sagittal plane should be centered to the midline of the IR. The patient's mid-coronal plane is vertical, and yeah, the central ray will be perpendicular to the IR, and it will be entering the level of T7. And also, you could use the inferior angle of the scapula. Again, my technique is average size male adult, 110 and 8. So time to take the exposure. Sir, will you please take a deep breath in, hold it, don't move, don't move. Okay, we've just taken that. So I'll take the IR out of here, replace it with a fresh one. For the lateral chest, be doing portrait. The SID is still 72 inches. So now I'm going to have the patient move from this position to true lateral in reference to the tube. The patient will be facing that way in true lateral, left shoulder up against the IR. And same with the PA chest, same with the lat. I want roughly the upper border of the IR to be roughly 1.5 to 2 inches above the relaxed shoulders. Forgot to mention that with PA. You want that for both PA chest and for lateral. Now with this one, the patient's mid-sagittal plane will be parallel with the IR. The thorax centered to the grid, roughly right here, and the mid-coronal plane will be perpendicular to the IR. I'm going to have the patient put his arms up above his head like this. If he can, hands on opposite elbows. And again, the central ray is perpendicular to the IR, and it enters the patient at the level of T7. And when we want it to enter the patient on the patient's mid-coronal plane, again at the level of T7 and the inferior angle of the scapula. For chest, I like to double the mass and add 5 to the KDP for lateral chest because it has a lot more body to go through. So for homeboy here, with PA chest was 110 and 8, so we're going to do 115 KDP and 16 mass. And like the PA chest, the exposure is taken at full inspiration. When I step back. Sir, will you please take a deep breath in and hold it? Don't move, don't move, don't move. Breathe and relax. Now it's time to move on to the knee. First, we'll be doing the AP knee. I need to set up for that. We're going to be using a 10 by 12 plate I'm going to put it in portrait and green bar toward the patient's head. SID is 40 to 48 inches. I like to do 40. Going to center to the middle of the table. Check. Okay, we have proper detenting of the tube, IR is in the bucky, the patient is on the table, and time to set up the console. For an AP knee, I like to do 65 and 5. The patient is supine on the table, pelvis not rotated. The IR is in the table bucky, and we need the femoral condyles to be parallel, with the table.
Doesn't go side to side.
It doesn't go side to side. Okay. I'm going to have to position the patient myself. So the patient is supine on the table, pelvis is not rotated, the IR is under the patient's knee, and we want the femoral condyles to be parallel with the table. That is a position for a true AP. Now, a central ray enters roughly ½ inch inferior to the patellar apex. Here's the patellar apex, and here's where the central ray enters. So I have that correctly. I've got a few inches of tib, fib, and femur on each side. And you angle the tube according to the patient's body type. You angle 3 to 5 degrees caudad for a thin pelvis, 0 degrees for a medium pelvis, and 3 to 5 degrees cephalic for a thick pelvis. Homeboy is a completely average adult. So we're going to leave it at 0 degrees angulation. Okay. For the knee, because we're only getting the knee, I like to shield the entire patient. Okay, now I take the image. Don't move. Now for the medial oblique knee, the SID is the same. It's 40 to 48 inches. The patient's body is in roughly the exact same position. The knee, what's different about this from the AP is you rotate the affected side medially 45 degrees. If you need to, you can elevate the patient's affected, the hip on the affected side to make sure you get that 45 degrees. And again, tube angulation for